success rates of IVF. That is what we're going to talk about today with Dr. Victoria Walker from Institut Marquès. So if you have any questions about success rates of IVF, already here, and I'm accepting the invitation so we can get the conversation started.
There we are.
Hi, Dr. Victoria.
Hello, nice to see you. How are you?
Nice to see you. I'm okay. How are you?
Yeah, no, I'm fine. Busy day, but it's really nice to see you.
And thank you so much for taking the time to talk to us today about such an important topic that I know that's one of the key questions that patients have is around success rates. Mm-hmm. And it's so complex to explain to patients the nuances of success rates. So if we start from the beginning, what can we say about the overall success rate of IVF?
It's very difficult. It's very difficult to give a useful number because it's so variable, it's so multifaceted. I mean, there was a study published in the middle of last year in Human Reproduction, one of the big things that we look at, one of the papers that we look at a lot, and they said that over 3 years, the average was about 42% of women who will achieve success. And that doesn't take into account so many different things that we're going to go through now, I think.
Yes. So what factors matter the most on IVF success?
Well, I would say more than anything else, age. It's just age. I mean, there are other fundamental things, you have to have good sperm, you have to have good uterus, you have to have maybe good protocols, you have to have an excellent embryology team. But fundamentally, I think the success rates, more than anything else, are related to the age of the woman. Really, that's everything more. Well, more than it. Yes, most.
And that is one of maybe the main factors why over the years since IVF was invented that we haven't been able to increase dramatically the success rate of this treatment.
Yeah, probably that is it. And women are leaving it later and later. We know that age is vital, but society is such that nowadays people just don't have time to try and make their children when they're younger. They're trying to do their careers, they're trying to get a house, there's so many other things going on, and they're leaving their fertility behind. And we wait and we lose our chances, unfortunately.
So what is it about age? What happens to the body as we age that impacts IVF and the success of that treatment?
Well, if you're under 35, your chances of success are very good. You can have about a 70% chance of success if you try a few times. But if you're in your early to mid 40s, it's often between 0 and 5% or so. And so how do we try and work out the chances of success? We look at factors like AMH, the anti-Müllerian hormone. This is a hormone that comes from the ovaries, the outside of the ovaries. It's related to the number of follicles that you have. And traditionally, people always said, well, if you've got a low AMH, you've got a low chance of being successful. But that's not quite true. It all relates to your age. So you could be like in your 30s and have a very low AMH level, and you may only make 1 or 2 eggs, but the genetic quality of those eggs will be so good that your chances are actually quite high. Whereas you can be in your 40s and still have a very high AMH, but that that translates into lots of eggs, but the genetic quality of the eggs is poor. So then you get very low chances of success. So age is a difficult thing. I mean, well, we can see how old we are, but our ovaries don't always reflect how old we are. and the AMH is a tool that we use, but it's not always that. It's not definite. That's right.
Yeah.
That's right.
That's a very good point, because I imagine for me in my 40s, I may have the same AMH as my sister who is in her 20s, but of course the same AMH has very different prognosis for both of us.
Right.
Because that's what you're saying, that the quality of my eggs is much reduced compared to hers.
Usually. That's what we would expect. That's what we would expect because you're older. That's all. Even if you've got a similar AMH to her. Yeah, you're older.
And how about the sperm? Does the sperm affect the quality or the success of IVF as well?
Very much so, very much so. So here at Institut Marquès, we have a lot of women who come and need egg donation. And so they're in their 40s and they need this treatment because they've reached the age where their eggs can't be used anymore. And then when you take the history, you realize that they've been trying for sometimes 10, 15, sometimes up to 20 years. And so now they need egg donation. But what explains the absence of pregnancy when they were 10, 15, 20 years younger? When their egg quality was probably very good. And often you might find something wrong with the uterus, but often you'll find that it's a sperm problem at the root. The root cause was often related to the man, or, well, not always, but you can definitely find that, and we find that a lot. So we are very focused on studying men as far as we can, and they're a vital part of everything. And they definitely can affect a woman's chance or a couple's chance of falling pregnant.
And when they've been for so long without identifying that potentially the man was a possible factor, is it because many doctors are not looking at the man as thoroughly as the woman? Or is there still some stigma thinking?
No, I think it's traditionally thought that if the sperm looks okay under the microscope, so you've got good concentration, good motility, good percentage of normal forms, then it's all right. And if it's not quite as good as you'd like it to be, then if you use ICSI, you should be okay.
Yeah.
But that doesn't take into account the genetic abnormalities that can be present in the sperm and that can give significant problems to people when they're trying to fall pregnant.
So we have the quality of the egg, the quality of the sperm, and I imagine the quality of the uterus and having an environment also impacts the success rate.
Very much so, yes. So, I mean, most women will have a standard uterus, but there are lots of women who've had surgery on their uteruses. They've had maybe they've had some ERPCs, the scraping out of a pregnancy when it hasn't gone well. And these things can leave problems later on that can be detected. You can do biopsies of the lining, you can do hysteroscopies to check the cavities and things like that. So yes, the uterus is, the nest, as it were, is vital too. Yeah.
And is there anything that either women or men can do to improve the chances of being successful with IVF? Maybe improving, I don't know, the quality of the eggs, the sperm, or the uterine environment?
Well, they can, yes. I mean, you can look at, first of all, at somebody's lifestyle. So you would be, I mean, there are easy things. Well, they're easy to say, they're not necessarily easy to do. Things like stopping smoking. You wouldn't recommend that either partner would smoke because that can affect the sperm and it can reduce the chances of success with the eggs as well. Alcohol affects particular testicular functions, so we'd recommend that men reduce their alcohol intake. I'm not sure that it definitely affects the eggs as much, but as women are trying to fall pregnant and they know they're going to have to stop in pregnancy, they generally have reduced very, very much as well, and usually stopped completely. Trying to be your own weight, the proper weight for your height is important, because we know that when you're carrying a little bit of excess weight as a woman, you get maybe fewer eggs on IVF, you might not get so many blastocysts. There are things, there's some evidence about that, and it's not a nice topic, but it's important as well. And weight can be important for men as well. And there's, you know, if you follow a Mediterranean diet, lots of green vegetables, that can improve the quality of everybody's gametes, as it were. And then trying to do exercise can be important too. So trying to keep yourself active, not too much. I mean, professional athletes have to be careful. Female professional athletes can lose too much weight, and that throws their hormones out, and male professional athletes can also affect their gametes. And sometimes we tell men who do an awful lot of exercise to try and reduce a bit. But being sedentary isn't ideal either, so a little bit of exercise can sometimes compensate for maybe being a bit overweight and things like that. So all of those things just in the lifestyle area can be useful, can be very useful.
That's really interesting, because then that can make people feel that they are involved and they're trying their best to influence
well, this is it.
treatment.
People need to feel like they're doing their thing. It's not enough to feel like the lab's working for them. They're doing it. It's them. It's for them.
Yeah, because if we think about making a baby, initially it's just a couple, and then it starts being the doctor and the embryologist in the lab, and it couldn't be most different to what they thought it would be. So still feeling involved is good.
And it's horrible to have to go out of the bedroom. People don't want to go out of the bedroom. They want to stay at home and just do it naturally. And when you start to involve all these other parties, however vital they are, it's not nearly as nice. So if you can still work on the part that you can control, it does, I think, help a bit.
And Dr. Victoria, I'm thinking, we were saying in the beginning that it's really challenging to come up with an overall number for success rate, because so many things impact success rates. Is there certain medical conditions, apart from the age, are there medical conditions that maybe lower or impact the success rates?
Well, in the kind of gynecological field, you've got things like endometriosis, for example. That's a very common problem that many women suffer from, and may give some painful periods and things like that. But it also can reduce their ovarian reserve quite considerably. And so, like, treatment for that can often be surgery, but sometimes the surgery, which is so good for the women from a symptomatic perspective, they feel much better after surgery when all the adhesions that they might have been released. That can often reduce their ovarian reserve even further. So sometimes for people with endometriosis, we might recommend that they try and collect eggs or make embryos before they go for surgery to make them feel better, and things like that, and before they maybe have a pregnancy. Another one that would be very common in our field would be polycystic ovaries. So that's where you get lots and lots of follicles in your ovaries, which you would have thought would increase your chances of success, but unfortunately definitely doesn't work that way. For some women, they just never have a period, and that makes it very hard to fall pregnant naturally. And for those women who have that particular problem, you can try nutrition and take inositol and try supplements that can make a difference. Again, sometimes weight loss will help, but I've known people with polycystic ovaries who are exceptionally slim, and so sometimes it's got nothing to do with weight at all, and they sometimes will need medical treatment, not necessarily IVF, but they might need some help along the way. So there are quite a few of those conditions that are very, very common that we deal with all the time.
And I think a common one that we've been hearing a lot about recently is fibroids. At what size do you think it could be problematic? Because I think lots of people have fibroids, and some of them don't know they have them.
That's right. Well, the reason people don't know they have them is that they might not give them any symptoms. Typically, fibroids, if they're problematic, will give you very, very heavy periods, and maybe slightly painful periods as well. But they don't normally give you necessarily very much more than that. And the fibroids, it can depend on where they are. So if they're on the outside of the uterus, even if they're very big, we wouldn't necessarily take them away. We wouldn't recommend taking them away because it's not going to necessarily improve your chances of success, and you shouldn't be reducing them. But the fibroids, if they're on the outside of the uterus, is okay. If they're in the muscle, that's usually okay. But if they're actually changing the shape of the inside of the uterus, so the endometrial cavity, then often we will recommend that they're taken away. And it doesn't usually from about 1 centimetre onwards you'd be recommending that they're taken away. But they really you have to be quite certain that they are distorting the uterine cavity, because we really don't want to go in and make a scar line on the inside of the cavity if we can avoid it. So it's only those ones that really, really affect the inside of the cavity we would recommend taking away.
Dr. Victoria, I think someone sent a question here, and the question is, after ROPA, does the gestational mother can have the same chances of having a child that is genetically hers as before?
So with the ROPA technique is shared parenthood. So you've got the eggs from one woman being made into an embryo, and then you take the embryo and transfer it to the recipient, to the other partner. And so the question is asking whether the recipient, after she's fallen pregnant with her partners, she might be able to fall pregnant again naturally. It depends on her age and depends on her ovarian reserve and things like that. When she takes the embryo from her partner, if she falls pregnant with that partner's embryo, she has the chances of success of the partner. But when she goes back to using her own eggs, then she has the chances of success of herself.
Yeah.
Does that make sense?
And yes, and that's because the age of the egg matters the most.
That's right.
Compared to these other factors.
That's right, exactly.
That's really interesting. And in terms of the embryo quality and any genetic screening, can that improve the chances of IVF?
Yeah, sometimes. So traditionally when I started in IVF, everyone would say, the better looking the embryo, the more chance it has of success. But what we've seen is that that's often not true. So you can have a really young person who makes an embryo, and the embryo is a bit kind of ugly. It's not perfectly, it's got a bit of fragmentation. It's not a perfect embryo, but it's got a really good chance of success because the person who made that embryo is still young. Whereas a really good looking embryo can sometimes be genetically abnormal. So increasingly with time, they're doing more and more tests to try and work out if these embryos that look good or don't look so good are genetically normal. And at the moment, there's lots of research to try and do this in a non-invasive way. So looking at the metabolites that an embryo might make and things like that, and the proteins. But at the moment, the most common one that would be used would be PGT. So that's where you genetically test an embryo. You take cells from the outside of the embryo, the bit that would subsequently become, if the embryo works out, a placenta, and you analyze that. And that analysis can give you the genetic makeup of the embryo. And so what we think it really helps with is trying to avoid transferring embryos that are abnormal. So you're avoiding wasting time, as it were, maybe. But also, even if the embryos are all abnormal, which is always really disappointing for a patient, but at the same time, it gives them so much information information that they can use to then move forward. It can give them explanations as to why they're in that situation and what they might want to change if they want to change anything. So PGT is, for us, the most useful thing to improve the chance. PGT doesn't improve the chances of an embryo implanting. It just gives us more information and helps us to choose which embryos to transfer preferentially. So we'd often recommend PGT for couples who've maybe got a long history of infertility, and the woman is now reaching 39, 40. That's when we think it would be most useful, from those ages onwards. And it can be useful in slightly younger couples if they've had things like recurrent miscarriages, because it can tell you a bit more about what's going on and why things are happening. I think a lot of IVF is very frustrating because people just don't know what the root cause of their problem is.
Yeah. And I think a question that I think lots of patients ask is, how many cycles do they need to finally get pregnant? And I think, touching on another point, we see often in the US patients being transferred many embryos, whilst here in Europe we transfer 1, maximum 2. Does that impact as well how many cycles are needed, or can you help us understand a bit better?
It's how long is a piece of string? It's a bit like, what are your chances of success in IVF? It's very difficult to say because there's so many different things. There's evidence that 3 good cycles can give you a good result, or up to 7 cycles. If you keep going, you'll get there in the end. Most people will. But really, I think the numbers are kind of meaningless. I think because your case, if you're 32 with 10 years of infertility, or you're 41 with 1 year of infertility, your cases are not comparable. I think the really important thing is to think and to understand that you are almost certainly going to have to do more than 1 cycle. The person who falls pregnant first time is rare, and that's important. And going back to your question about how many embryos to put back, well, at the beginning of last year, there was a European directive that came out that recommended all fertility clinics only transfer 1 at a time. So that is what is ideal. It's true that if you've got lots of embryos that have been made in your 40s and you haven't done PGT, you could put more back in theory, because the chances of success with each embryo is so low that, you're probably not taking a risk. But we really don't want people to end up with twins or triplets or anything bigger than, none of those, because the risk is so high for the mother and for the babies. So even nowadays, that would be another reason for doing PGT, to try and minimize your multiple embryo transfers and just going for the good ones, and only transferring good ones, but 1 at a time. And I don't think there's really an argument nowadays for putting like 4 or 5 back, as they might do in other parts of the world. I don't think there are many places that do that now.
Yeah. Do you think there's going to be a trend in the US and those other places to follow Europe in that sense, into transferring just 1 or 2?
I really don't know. I don't know anyone who works in the US. I can't say what America doesn't seem to be following the rest of the world in anything else it's doing at the moment, but maybe in IVF, we never know.
Let's see.
We'll see, but really, I really have no idea. The few doctors I met a few years ago who were American were very, very serious clinicians, very good at looking after their patients, and would never have, transferred 4 or 5 at a time. So I'm sure they will be reducing, and I'm sure they do very rarely put more than 1 back.
And Dr. Victoria, is there any advancements in technology that could help either the lab or the couple improve the success rate, apart from PGT?
Yeah, well, I think there's research going on all the time in all the different labs all over the world, and the papers, we see just all these things being looked at, all these different aspects of embryology and clinical care that are trying to improve things. Here at Institut Marquès, we've done a few things. We've tried to introduce music into the laboratory, actually into the incubators, and we found that that improved the fertilization rate. So we do that still now. We think it's related not to the actual sounds of the music, but the vibration. So that's something that we brought in and helps all patients. And then you've probably heard of the EmbryoScope incubator, which is an incubator that takes photographs of all the embryos as they're evolving. And my colleagues and others around the world have noticed that some of the embryos evolve, but then they go backwards a bit. And that's called reverse cleavage. And initially everyone thought it was a bad thing if the embryo went backwards a bit. But now they've worked out, and we published a couple of years ago, that no, they can still go forward and they can still be viable even if they've done these funny things. So the research looking at the embryos to try and make sure you don't throw an embryo away that you think because it could still be viable, that's really important for patients. If they only have maybe 1 or 2 embryos, you don't want to throw something away unnecessarily. So we have all of those. And then in the future, I think everyone is talking about big data and AI analysis and things like that. I haven't actually seen any of that actually being used clinically here with us yet, but it's definitely coming and everyone's talking about it. So there's lots happening all the time, I think.
And Dr. Victoria, one final advice that you would give to couples who are trying their best to maximize their chances with treatment. What are a couple of things that they could take away?
Well, I would say, first of all, think about you as the couple. As we mentioned earlier, think about your health. Both of you look at your health. No smoking, no drinking, being your weight, doing a bit of exercise and all of that. See a nutritionist if you need help. They can be very, very good for men and for women. Then try and it's useful to do a bit of research on the field of infertility. If it's not something you're familiar with, just look it up, do a Wikipedia search, try to understand what these clinics are going to try to do for you, what the techniques they might use for you or the words they're going to use. So I would suggest a bit of research. And then look at clinics obviously close to your home because it's convenient to stay at home, but you might want to look a bit further afield to your biggest large town or city, and maybe look abroad because they may offer other things. And then when you've chosen a few, and there's some really good apps, there's the Fertility Mapper, they're very good for trying to help people compare clinics. There are a few places like that, apps online. And then when you've chosen the clinics or a couple of clinics that you like the look of, talk to the doctors and try to really understand what they want to do for you and why they're suggesting these different things. Make a few decisions with them, ask for their advice and make some decisions with them. But then kind of go ahead with the treatment, and I would suggest park it. Let them look after you. There are no clinics that I can think of that want bad results or unhappy patients. Everyone wants a good result. So there's no one who's going to actively make a negative decision. They want everyone to do well. So once you've made your decisions, just let them kind of get on with it and feel like you've done your best, and you just follow the instructions and try not to think too much about the end result, because you have to just live with the end result, whatever that is, and you have to feel like you've done your best and no one could have asked more of you. And I think if you feel like that, then whatever the end result, you feel a bit calmer and a bit more in control.
That is such good advice, and you're right, it's good to remember that we're all wanting the same thing.
Yeah,
Patients, the doctors, everyone.
Absolutely. I mean, most of our patients will come and they'll do a first visit with us and with another clinic and another one and another one. And in the end, it doesn't matter where the patients go. You want them to just have a good result wherever they go, be well treated, and you want them to be happy. And everybody wants that.
Yeah. And Dr. Victoria, I know, of course, the clinic is in Spain, but you will be in London soon, aren't you? Can you tell us a bit about that and how can patients book to see you in London?
That's right. So thank you for asking me about that. Yes, I'll be there. Next time will be March the 7th. I'm working on with Fertility First and Fertility IVF. And they have a clinic on Wimpole Street, and they've kindly offered the room for us for one day. And so I think I've got 6 visits for patients to come along. And anyone is welcome, anyone who's just a bit kind of confused about their fertility and what they might need to do. The visits are free. And I'd be really happy to see anyone just to come and have a chat. It's roughly every hour, and I could probably do more if they've got more time. So I could do more than 6 if more people want it.
Perfect. I will share that link in the stories as well today. So make sure that people have access to that opportunity, because it's such a good opportunity to have a medical opinion and connect with you face to face. And
it's always lovely to see patients in person. Yeah, and it's free. So that sort of allows people to just come and investigate. And I think that's nice for them. They can just find out a bit more. And I'd be very happy to see anyone.
Thank you so much for helping us understand IVF success rates, Dr. Victoria. And thank you for all your insights.
Thank you, Andrea. Lovely to see you again. Take care.
Bye.
All the best. Bye.